So it is called as Pandora's box simply because whenever there is abdominal pain, I mean, there are so many reasons. Same way when we'll be learning the nervous system, then we'll be learning after completion of nervous system, right? At the end, we'll be learning how to diagnose headache. Because in Harrison, right, it is said that to diagnose or to remember the causes of headache itself is a big headache. So these are the things which are so common. Same way the chest pain. I mean, this thing occurred just about an hour back to one of my good friend. Now, non-medical, and they were in so much of panic. So this is the chest pain management which we'll be discussing, because it will be comprising of respiratory system, it will be comprising of cardiovascular system. I mean, it could be a normal chest, normal muscular pain, to it could be a myocardial infarction. Now, what happens is that we learn respiratory system, we learn cardiovascular system, but it is in pieces. When it really comes to clinic, right? Because I always say that now you are a doctor. So in case if there is anything, right, whenever you go to someone's place, they'll say, "Correct, Doctor Saab, right? You are Doctor Saab. देखो ना यहाँ पे दर्द, heart attack to me." Now this is where a very systematic approach is needed. Now there might be few questions that abhi to first year shuru hua, and we are going for chest pain management. Yes, very true, because this is something which is like a skill. Right? A skill which is developed as you practice more and more and more. So by the time, seriously, chest pain, headache, abdominal pain, general body pain, and the fever. These are the 5 things. If you can in a differential diagnosis, trust me, it is more than 70% of the practice. Really, 70% of the practice is revolving around this. So, because we learned RS and CVS in detail, so I thought that chalo, we take this topic. Yes, as usual. Let's start. Yeah, I received 4 emails from you. That was a bit surprising. Just 4 emails. I think last time also there were about 20 people. Anyway, I'll discuss that thing later. So let's start with the chest pain management. Why chest pain? Because it has got wide range of potential causes. Right from the emails for what? Emails for, I think Sharon, you have sent. It was regarding what? I got here. So the email was regarding that what are your schedules in the college or the university? What are your schedules, whether it is offline or online? Because I wanted to plan something for you guys, but response was a bit cold. So I have not decided anything at this point. But anyway, let's move on to this point. Okay. No, because many of our friends, they are in other countries also. So that's why there was some overlap. There was some overlap in the lectures, timings. So when we talk about chest pain, so there is wide range. Right? It can start with a simple muscular pain. I mean, someone went to the gym and jara zyada weight se kar liya, to then maybe a muscle pull is there, which is not a very serious thing. But when it gives pain, so yes, that pain is bad. Or it could be all the way to life-threatening conditions like pulmonary embolism or maybe myocardial infarction, right? All those things. So that's why we cannot be haphazard. What I am about to give you is a very step-by-step process. Patient comes, and every time you handle the chest pain, you will be asking same questions, same questions, so that within few days, if you follow this practice, you'll be master. At least you'll be able to tell that whether this is a pleuritic pain, whether just by looking whether this is myocardial infarction, Whether this could be STEMI, non-STEMI, inguinal pain, everything would be crystal clear, right? And you'll be able to guide. Most important is you'll be able to guide the patient. So this would be our approach, that for the chest pain, one, we'll just see what are the causes. Now we'll be going for very common causes. We'll not be going for some rare causes or so those syndromes, etc. Because if you think of rare things, you are rarely right? So we'll not be touching that. The most common causes. After that, this would be our systematic approach. Now in this systematic approach, I'll take you all the way at the end to some of the lab tests. Those lab tests which are called as the cardiac markers, right? They are called as the cardio markers or the cardiac markers, one and the same thing. Two very important, one which is called as the troponin and second is called as the D-dimer. You must have heard of these things, D-dimer, especially during the COVID, right? People used to say, "Mera D-dimer pad gaya," right? My D-dimer, it touched 5,000, which is like a life-threatening condition. And why it was necessary to take that pill, which was so costly, but yes, because it was life-saving. There was a severe threat of pulmonary embolism. Right? So we'll discuss about this. So when you see the report, immediately you come to know that yes, this is the situation and what is to be done. That is more important. And third is, when I said management, okay, management, right? And we say management strategies, but in this we'll add something evidence-based, right? This is what we'll do. This is called as the evidence-based. What is evidence-based? Evidence-based is right now what is happening to the patient. It is important that you solve that thing, right? You solve that thing. Say, for example, if it is tension pneumothorax, don't worry about the infection. It is important you examine. Patient is telling that, yes, I had a gunshot, right? Or some stabbing. And you find that there is a small tissue which is hanging. And that tissue is acting like a valve. So that air which is going in, but it is unable to come out. Bindas, bluntly, just your little finger, whether it is gloved or not gloved, don't worry much about it and remove that tissue. Immediately, patient will feel so much of comfort. Thorax will press the heart, and then when you start watching the veins which are engorged, so that means condition is now worsening. Right? So we'll talk about these in a very systematic way. Step 1, step 2, step 3, step 4, and we'll start with very basic, very simple. Something what is will follow the same principle of inspection, that is you are watching, palpation, you touch, percussion, which is not needed usually in this case. Percussion is what? I mean, you can in case of pneumothorax. So percussion, if you remember, I said that you just put a finger and yeah, that sound, right? It's the feel of sound. So if there is pneumothorax, so there would be a blank, dull, resonant sound. And when the tissue is inside, what if the tissue rather than coming out goes inside? Does it make no worries? Nothing can happen because normally it won't go. But even if it goes down, no worries, it gets absorbed. So not much of the problem. But if it is acting like a valve, so then here it is like it can keep on increasing the tension to a very dangerous level. Or it can be felt through the bones. I will talk about it. I'll just show you. Through bones? No. Percussion is not done on bones. It is between, say, if you're doing it on chest, so it is between intercostal, it is into intercostal spaces, between two ribs. That is where you will be doing. Because bones, if the base is bone, so then it will be the same sound. Percussion would be of utmost importance, especially when we'll be discussing the acute abdomen. Acute abdomen means abdominal pain. Acute abdomen is the medical terminology for pain in abdomen. Right? It is called as acute abdomen. So that is where you'll do the percussion and you'll try to find out whether there is any increase in the size of, there is hepatomegaly, liver has increased, splenomegaly, spleen has increased. Is there any other mass which is felt? What is the position of kidneys, etc. So this is how we'll progress, right? So let's start on a fresh page. And that is, we'll start with a causes. Very logical. First, cardiac. Second, pulmonary. Right? These are the commonest. Now, in case if there is any gas in the abdomen, then also it can lead to chest pain, right? Because the diaphragm will be pushed and that leads to discomfort in the chest. What if the muscles are involved? So we talked about musculoskeletal, right? Musculoskeletal. And fifth thing, this is psychogenic. I mean, suddenly lottery lagi hai, right? So, or if there is some bad news, so then also it comes to chest, right? Panic attack, anxiety, right? Psychogenic. Now, yesterday, if you see the share market fell like it was bloodbath, right? More than Sensex went down by more than 1,200 points. So, yes, obviously, everyone would be suffering the loss, but when you read the book of Charles Munger, he said when everyone is in panic, that is the time to buy, because you will not be getting the shares at this rate. But what happens that those who are not understanding it, right? Literally, there were 3 patients, right? My friends, my chartered accountant, they were in panic, and they said, "Sab chest pain." Right? Yes, it happens. That is what is called as the panic. Right? So let's decipher all of them one by one. Plus, remember, when we are talking about cardiac, we will be going in. I'll be telling you some extra things also, right, which will be very helpful. Everything on one individual page. So let's say we start with cardiac. In cardiac, commonest thing, that is what is called as the acute coronary. Because everything revolves around coronary, right? Coronary arteries, coronary syndrome, commonly known as the ACS, acute coronary syndrome. Why we said coronary syndrome? It means because these coronary arteries, they are supplying to blood. Now, even if it is supplying less blood, then also heart is crying. Heart has not, say, when we say infarction, that means the muscle tissue has started dying. When we say angina means heart is crying, it's telling I'm about to die, right? De do thoda blood. So that's why in both the cases, coronary is involved. So that's why in general, broad term is acute coronary syndrome. Easy, right? So we divide it in like this, because you need to diagnose precisely what it is, right? So now think of like that you are into final year, right? Because you have got the entire foundation, entire base ready. So don't feel like that you are into first year or first kuch nahi. You are into final MBBS, right? Where you can and trust me, not a single word would come which you will not be able to understand. So when it comes to acute coronary syndrome, right, how to first chest pain, मान लिया, right? So let's see what really happens. One which is called as the angina, anginal pain or angina pectoris. Pectoris means chest, angina is pain. So angina pectoris, right? When this is there, it means less blood supply. Less blood supply. Tissue damage? No, there is no tissue damage. But it is the cry of the heart. Pain, jabardast. Pain would be massive. So that is angina pectoris. And second, what is called as the MI, myocardial infarction. Myo means muscle, cardial is heart, and infarction, that is because of the lack of the blood tissue has died. So myocardial infarction. Right? Now this is divided into 2 types. Anyone, when we take the myocardial, when we take the ECG of myocardial infarction, what is the prime thing which you get in ECG? You see that and you say that this is MI, full-fledged MI. What is that? One word, I mean, just keyword. What is that? Superb. Very nice. Arrhythmia, Nirman. Beta, arrhythmia to afterwards. I said ECG. Right? ECG means it is ST segment elevation, ST elevation, or you can say ST elevation. Perfect, ST elevation. So how would it really look like? Let's draw it here. Yeah. So this is normal, P, Q, R, S, and T. Right? This is P, this is Q, this is R, this is S, this is T. This is the normal ST segment. This ST segment is elevated. So in this only I draw. ST segment goes like this, that high. And if this is what is called as the ST segment elevation, and if this happens, it is most dangerous, most in capitals, most dangerous. But the interesting part is, now we are going slightly into histology, right? Broadly, so this is the muscle, right? Muscle, and this part is the inside one, which is called as endocardium. Right? So when this is where the infarction is, right? When the infarction is this much, so then this is called as the subendocardial ischemia, right? This is called as the subendocardial ischemia. So it means the entire thickness of the heart is not involved. But when the entire thickness of the heart is involved, full-fledged, right? The entire thickness of the heart is not getting the blood. This is what is called as the transmural ischemia. Right? Yeah, transmural ischemia. So very simple, transmural, entire thickness, and subendocardial, obviously only a small one. So myocardial infarction is divided now into clinically two types. One, what is called as the STEMI. Kuch nahi, very easy. ST elevation myocardial infarction. Easy. Right? So ST segment elevation myocardial infarction. It means that ST segment is elevated, and what type you are handling? You are handling transmural ischemia, right? This is what we are handling. It means full thickness. That's why it's more dangerous. So what other type would be? Other type would be non, right? So it is called as non-ST elevation myocardial infarction. STEMI. Non-STEM, N-STEM. So this means here we are dealing with subendocardial ischemia. Subcardial. Again, there are two parts. That is what is called as the acute and non-acute. Right? But it is very easy. It is very easy. Let's take it over here. Right? So here it is the subendocardial ischemia. If it is right, so remember it is non-STEMI. So ST segment would not be elevated, right? ST segment is not elevated, and we have got two types. One, which is developing gradually, right? So it is normally called, it is the gradual onset. So in that case, any guesses? During ECG, I said that ST segment first goes down and then it starts rising. And as it rises, it is bad, worse. Correct? So this is what really happens. This is how P, Q, R, S, and T. This is what is called as the ST segment depression. Correct? So this is P, Q, R, S, T. So this is ST segment depression. History is telling patient is telling sudden pain and sudden pain. So that means we are dealing with acute subendocardial ischemia. Correct. So in this case, very interesting. ST segment at times it is normal, sudden development. So that's why ST segment normal, T wave inverted. So you got a patient with chest pain, you take the ECG and first thing which you notice, this is Q, R, S, and T. T wave inversion has started. This is acute. Can lead to this ST depression, and if not treated, and if you are monitoring it, and as you find that this ST segment is rising, you know what it is, right? So this is Q, R, S, T. Oh, sorry. P minus T. This is P, Q, R, S, and this is the T. This is our focus. T wave is inverted. T wave inverted, that is acute STEMI. Clear? And when it comes to ST elevation, myocardial infarction, very easy. We discussed it. P, Q, R, and then straight away is this. Right? This is a classical picture. P, Q, R. This is ST. ST is raised. That ST segment is raised. So that is ST segment elevation. So now we, from the ECG, we know that what we are handling. So what we are handling. So this is in the cardiac, first thing, the acute coronary syndrome. Right? So now we know that what happens into this coronary syndrome. How the patient would be presenting. Now this, I'm changing the color. ECG to baad mein aata hai, but how the patient would be coming up. Patient will come with one, retrosternal pain. Now this is, as I am speaking, you need to imagine, right? Retrosternal pain. Pain is not directly onto the left side. Sternum, just underneath the sternum. Could we write the full form so that we, I mean, STEMI and non-STEMI you are telling? STEMI and non-STEMI? Okay. I'll write it. Right? STEMI stands for ST elevation myocardial infarction. This is fine, right? You can decipher. And non-STEMI is, I'll just write it is non-STEMI, correct? Non-STEMI. So retrosternal pain. Pain is in, and then it radiates to, see where it can radiate. So radiates to arm, shoulder, neck, right? The entire line. So let's start writing from here. It can go to jaw. If it goes to jaw, it is very bad, right? If it goes to retrosternal means yes, behind the sternum. So it is not typical left-sided chest pain, because see, this is the sternum. The heart is like this. Who knows the myocardium, right? It is the right ventricle which is involved, so which is just underneath the sternum, right? Not every time the left ventricle is involved. If it is left ventricle, so yes, it would be the left-sided pain. But if it is right ventricle, or so it can really, so better to remember it like this. Right? Retrosternal, then it starts radiating towards the jaw. Right? If it goes towards the jaw, later we'll discuss, when we will discuss it in medicine, why it is so bad when it goes to jaw and the subscapular area, right? So from jaw, neck, right? See the neck, then shoulder, shoulder. So much so, it can give pain to the arm. Person will be doing like this, right? Shoulder, arm, and the back. Typically, your in the retrosternum, retroscapular area, right? Scapular area. So over here it can go. Another thing which you need to remember is it is called as the diaphoresis. Diaphoresis. This is the medical terminology for abnormal sweating. Right? It is the abnormal excessive sweating. Now, in movies, sometimes they show this thing. So this is real. Right? Even chilled AC person is sweating like anything. Right? So this is abnormal excessive sweating for no apparent reason, and then starts the nausea. Now everything is fine, but there is one word which is not mentioned in any of the books, right? Because there is no English word for this. But Hindi mein, it is called as the ghabarahat. Patient would be ghabarahat ka koi. So we used to write even in history also that patient start feeling ghabarahat. Right? We literally wrote it like, we used to write it like this. Ghabarahat. But this is the typical sensation. This is the typical sensation, that ghabarahat. Right? So when this happens, because it is like a very panicky situation, right? Because vagus is stimulated like anything. Nausea, then diaphoresis, right? Abnormal excessive sweating, everything, they will be on fire. So when these symptoms they are occurring, so remember this is acute coronary syndrome. Uneasiness, तो दोस्त यार तूने बहुत छोटा वर्ड बोला. Uneasiness तो मजा नहीं आ रहा. घबराहट is when मतलब you feel like someone is there. Anxiousness, right? So this is like as if किसी ने gun रखी है सर पे. That feeling. All these things are on one patient. Obviously, all these things would occur, right? When the patient is having acute coronary syndrome, all these things would occur. Okay, so keep this much in mind. This patient is not yet over, because when we'll be going to labs, that what lab report you should go for, a simple lab report, and within seconds you'll be able to diagnose what exactly are we dealing with. Okay, so then second thing is, now we change the color. Second thing is, patient could have pericarditis. Pericarditis, which is not that bad. Which is not that bad. There would be pain, but the typical pain is, this type of pain is called as the pleuritic pain. Right? It is called as the pleuritic pain. Now, what happens in this case? Pleuritic pain, it takes a second to diagnose, because this will be coming into even our pulmonary causes. So, pleuritic pain, in pleuritic pain, this is worsened by coughing, deep breathing, because it is the pleura which is rubbing, right? The pleura which is rubbing with each other, it is the pleuritic pain. So pleura is very sensitive. So when they start rubbing, so this is because of pericarditis. Pericarditis means, the layers, right? There is inflammation because of that, right? When the pleura rubs, so it is worsened by deep breathing, and it is also worsened by coughing, right? Coughing. So how this patient would be sitting? This patient would classically be sitting, leaning forward, and he'll be comfortable, right? So remember this point. Pain is actually relieved by leaning forward. Now, patient is not supposed to know the anatomy of lungs, right? Like, he'll not be telling because I'm having pleuritis. No. The thing is, it is the natural reflex that patient will be leaning and he'll find, yeah, this is good. Now I can, pain is less. So he'll remain in that position. If he's sitting, if on the round, you'll see, so they'll put a table or a table pe aise sir jhuka ke baithe, right? They will be leaning like that. Immediately you know that this is pleuritic pain. So either it could be due to pericarditis or it could be because of the pneumothorax or the serious matter is pulmonary embolism. So immediately you just take the oxygen, right? We'll come to that. But you take the oxygen, and if the oxygen is low, you need to go for angiography, pulmonary angiography, CT pulmonary angiography, because you are suspecting a severe case of pulmonary embolism, right? But it is a very typical thing. Okay, so pericarditis, this is the pleuritic pain. How this is itis. Itis means inflammation. There would be history of fever. And fever kaisa? Viral fever. Viral fever. It means it will not be having any pattern. Right? Patient is taking paracetamol, the fever chala gaya, then it comes back. Right? So typically it would be like this. So these are the two major causes. Otherwise, other causes are like, say, aortic dissection. Aortic dissection means when this is the aorta, right? And when wall of the aorta, it gives way, it is torn. So that pain is like a tearing pain, as if kisi ne chura maar ke koi cheer raha hai, that type of pain. But okay, I'll just write it because that is also important. So it is the aortic dissection. It is called as aortic dissection. So here the pain is tearing pain. This pain is even bad than the myocardial infarction. Can a patient with no history of heart problem undergo angioplasty? Normally, I mean, if there is no history of heart problem, then why the angiography was done? Because angioplasty is the next step. Why the angiography was done? And if the angiography was done, I don't know whether this lecture is getting recorded or not, because you cannot say certain things if it goes online. But anyway, the thing is, let's put it into a bit decent words. Angiography, it is like a joke, but it is true. Angiography is shown to 5 cardiologists, and all 5 they gave different report. From normal to go for immediate bypass. It has happened. It happens. It's a very subjective thing. So sometimes when you see, and you will find that, oh, these are the basic principles. Forget about the commercialization. You might say that no, there is no need. And patient survives, yes. Best example, my lawyer's father. Right? And they said, go for immediate bypass. Now, more than 6 years have passed. He's absolutely fine. So, anyway, I'm not telling that every time it is wrong, but this is with reference to what you wrote. Right? There is no heart problem, so then why the patient was subjected to angiography, and when he was subjected to angiography, no signs, symptoms, nothing, so then why the angioplasty was done? Okay. So this aortic dissection is when the wall is broken, right? Wall is broken. This wall damaged. And when the wall is damaged, then that gives the pain like anything. Now, aorta is a very tough structure. If you really see the histology to right, it is a very powerful, very tough structure, not easy to break. Who can break? Only 2 things. One, hypertension. If the person is having blood pressure, high blood pressure, then high blood pressure is always generated by the left ventricle. Aorta is coming out of left ventricle. So aorta will be taking the entire brunt, right? That high pressure, and when the blood is sizzling pass through it, so it can damage the wall. Or there can be another thing like connective tissue disorders. When the entire body itself is so weak that the connective tissues, they are breaking apart. But in that case, there will be so many other complications. So right now we'll not be talking about connective tissue disorder because it is one of the very long topic. right? Almost more than a week is needed. So these are major things. So that's why, see, if this is someone is having high blood pressure, it is dangerous. Right? So these were like what we discussed were the cardiac causes, right? These were the cardiac causes. We now move on to the pulmonary causes. Pulmonary. So it means it will be related to pulmonary system. Starting with the most dangerous one. Pulmonary embolism. Life-threatening. Pulmonary embolism. I remember it because during COVID-2, right, there was severe threat. Right? I'll tell you the reports also that what really happened. So everything was present. There was pleuritic pain. So pleuritic pain, right? You lean and you sit. So for a whole night, right, you are sitting on a chair because that's so comfortable. You are constantly watching that your heart rate is going soaring above 100, right? Tachycardia. And third thing is that you have put the pulse oximeter and you are watching it is going on 82, 84, 81, hypoxemia. Right? Hypoxemia. Low oxygen level. This is a threat. This is a severe threat. Pulmonary embolism can develop, and if it develops, it is called as the PE. If it develops, then gone. So this is typical. These are the three. They are called as the triad. Triad means three. Second, when someone complains of chest pain, watch history, pneumothorax, right? So in pneumothorax, there would definitely be history of injury, right? But here in pneumothorax, he'll be having pain. He'll be able to typically show that yes, pain is occurring here, at one point, right? On one side. So it is what is the unilateral chest pain. And it would be quite pinpoint, quite specific, unilateral chest pain. In myocardial infarction, patient will be holding like this. In pneumothorax, he'll be holding like this. Right? The point where it is developing. Plus, in case of myocardial infarction, patient won't be breathless, patient would be sweating, right? There would be ghabrat. He'll be able to talk to you. That, "Arey, bahut dard ho raha hai, ye ho raha hai." He'll be able to speak so much, right? You have to say, "Chup, bolo mat." While in case of pneumothorax, patient would be breathless. Why breathless? Because lungs are getting compressed. Lungs are getting compressed, so patient would be breathless. Right? So over here, you'll find that there would be history of injury, whether it is accidental injury or some chura, gun, of those things. The third, which is quite general, pneumonia. Right? Pneumonia. So when pneumonia or the consolidation, right, when there is infection, so here also there would be pleuritic pain. Got it? So here also there is pleuritic pain. So patient would be quite relieved, but it would be associated with fever. It would be associated with cough, and it is gradual onset. History would be long, right? In case of pneumonia, you take the X-ray chest, and then you find that yes, and you know that all these parts, right? Okay, if the upper lobe is involved, so you'll be able to see this horizontal fissure. If the middle lobe is involved, so then heart border is obscured, because the middle lobe and the heart border, right? They both will be having same type, same density of the tissues, so we won't be able to differentiate it. And if the lower lobe is involved, so obviously the diaphragm, that would be obscured, that would be blurred, that would be seen. So just a simple X-ray chest will be able to tell whether it is upper lobe, middle lobe, or the lower lobe. Right? So this is what we'll be looking into the respiratory system. See, till we are just understanding what could be the causes. Right? Now comes the GIT. Now this GIT, though we'll be discussing GIT in complete detail, but the most common one, which is called as the GERD, gastroesophageal reflux disorder. And kabhi na kabhi to you must have felt that. In simple Hindi, khatti dakar, मतलब क्या हालत होती है, राइट? मतलब पिज्जा ये वो कुछ भी तीखा तला, and then when it comes back, right, आंख में से नाक में से पानी. That is medically known as the GERD, gastroesophageal. सोया के बाद तो इट इज, चलो फिर भी मतलब इट इज क्वाइट ओके. मतलब इफ कहीं शादी में बकवास खाना खा लिया, राइट, एंड देन दैट थिंग कम्स स्ट्राइक्स बैक, इट इज सो बैड, राइट? So gastroesophageal reflux disorder. So here in this case, this is also a retrosternal burning pain, right? Here the pain would be there because this is the path of esophagus. Now esophagus has got no protection. Stomach has got wonderful lining, so that acid is not doing any. But over here, this acid, it starts coming up. When it is coming up, so this esophagus is crying. So it is the cry of esophagus, and that is what is leading to retrosternal burning. Now see, retrosternal pain and retrosternal burning, we talked about it, right, in the infarction. So that's why you need to ask, कैसा दर्द है? If you say साहब जल रहा है, if you like this जल रहा है, खाना खाया, say yes, this is the thing. It is worse after meals. It is worse after meals because after meals only that thing is pushed up and it is leading to this problem, right? So this is one very commonly it can occur. It can occur because of the emotional surge also. It can occur because of some overdue exercise or so many reasons. But yes, contents are coming back, correct? Next is peptic ulcer. Now alcohol, stress, right, or all smoking, all those things, they can lead to these ulcers. So peptic ulcer disease, it can occur. Now two types of ulcer. So this is the stomach, and this one is the duodenum, right? So this one is stomach. This is first part of duodenum. This is second part of duodenum. This is third part of duodenum, and fourth part is retroperitoneum. If the ulcer is very interesting, if the ulcer is into stomach, so we call it gastric ulcer. Just from the history, you will be able to diagnose or gastric ulcer. So gastric ulcer, you ask the patient, खाना खाने के 15 मिनट के बाद पेन शुरू होता है. So that means it is definitely gastric ulcer, right? Pain worsens after 15 to 30 minutes of food. So that is gastric ulcer. If it is duodenal ulcer, if it is over here, we call it the duodenal ulcer. History would be totally different. So how would it be? When the patient, because these are long-standing things, right? These are like lifestyle disorders. Gastric ulcer, patient would be quite lean, and for no reason weight loss हुआ, because patient को खाना ही नहीं अच्छा लगता. कुजिल से क्या खाते हैं तो पेट में दर्द होता है, नहीं खाना रहने थोड़ा कम. Duodenal ulcer, right? Pain improves after meal, right? After meal. So they are hatta katta, right? They'll eat extra. So this is very easy to diagnose. When you just take the history and you'll come to kya hai. Then obviously the treatment and everything is totally different. But this is in general. And over here, where would be the pain? Pain would be when the ulcer pains, they are into epigastric region. Right? Pain goes away, or it decreases. And many times it won't go away, but it decreases. Right? Pain improves or decreases. Right? Decreases. Wonderful, Ruchita. ये जो question है ना, what she asked is that if we know pizza, burger, etc., they are bad for health, then too, why does craving occurs? The craving occurs because three major reasons. One, they put this monosodium glutamate. That is something which affects the brain. Second, these are high carbs. High carbs. Right? Carb craving is such a thing that even in gym, after doing so much of exercise, right? मतलब आपने cycle चला, you burnt 500 calories, and then वहाँ पे pizza hut है, तो then you feel कि यार एक खा लूं. Now one pizza that would be 600 calories, but yes, still because those high carbs, it is called as the carb craving. Carbs craving. If you can in your life, if you can control this thing, carb craving. And third thing is sugar. In all these burger and this in those sauces, there is so much of sugar. Now sugar craving, it is 100 times more than cocaine. This is true. When we'll be learning neuro, at that point we'll be learning in depth that what really happens in the case of addiction. But sugar craving or the sugar addiction, it is 100 times bad than the cocaine. Right? So the person will be craving for it, and that craving is so high that खींचे चले जाएंगे, चलो, let's have it. Then बाद में देखा जाएगा. And then the more intelligent you are, the more intelligent excuses you will be giving. Right? So this is true. I mean, if someone is not knowing these things, तो उसको बोलो कि चुप नहीं खाना, और ठीक है सर नहीं खाएंगे. But then we say कि नहीं, because say this carb will be giving this much calories, so it is a matter of 600 calories now. No problem, right? Gym जाते हैं, cycle चला लेंगे, 600 calories will burn it, no problem. अभी खा लो. So you will be giving more and more. और आज तो इतनी पढ़ाई की तो कुछ तो reward चाहिए brain. All sorts of wonderful excuses we start giving to ourselves. This is what really happens. Why it otherwise, seriously speaking, right now you are in the best phase of your life. But look at many of the doctors, you will feel, yeah, he is gastrointestinal surgeon, GI surgeon, right? Gastroenterologist. And look at his tummy. मतलब 50 इंच का तो tummy है. Right? So he is telling everyone, but he is not thinking about how much visceral fat I got. आधा किलोमीटर चलने में हालत खराब होती है. तो aren't they intelligent? बिल्कुल, इतनी बड़ी हॉस्पिटल ऐसे तो ना बना रखी है. They are watching 100 patients every day, but still शाम हुई, चलो आज बहुत काम किया, and they will eat junk. They'll eat junk. So these are the major things, very important. So, but you know, this is a matter of habit. If you develop good habit, that's why there is one very good book. It is called as the Atomic Habits. Right? If anyone is interested, I got a PDF also. If interested, let me know. Right? Then I'll send it across. Cakes are also included junk. Kushi 100,000%. 100,000 cakes. तो मतलब दोनों चीजें, मैदा, right? That white flour, मैदा, and loads of sugar. They're absolutely bakwas. So this was GIT. GIT में अभी इतना ही. And next is musculoskeletal. Musculoskeletal system. In musculoskeletal system, this is what you'll find in old age. Right? In old age. Now, in this one, and that is called as the costochondritis. Costo means costo, that is rib. Chondritis means cartilage. So this is the rib, and then from the rib, rest of the journey, that is by cartilage. So this is a bone, right, or the rib, and this is the cartilage, and then this would land onto the sternum. Correct? Sternum. Because it gives flexibility. But when as the age increases, this joint, right, that starts ossifying, and the costochondritis is like a very painful thing. But what type of pain? This is a pain which is a localized pain, and when you press, so it will give pain, right? So localized pain, very typical history would be there, right? Localized pain, no fever, no breathing problem, right? Nothing. But when they breathe, they won't be breathing like full-fledged breathing. They'll be breathing bit shallow. Bolenge bhi dheere, right? It irritates, right? And this is where the palpation will come into picture. You'll say कि यहाँ पे दर्द हो रहा है, and you put your finger and you press, and they'll say, you don't have to ask कि दर्द हुआ, right? Because in palpation, it is like never ask the patient दर्द हुआ, because अगर जो दर्द नहीं हुआ होगा ना, तो भी कहेगा हाँ हुआ, right? So never ask, just press bindas, right? Patient will himself give the signal. So it is reproducible with palpation. So today only, right? So when my friend's wife, she called up, he said he is having pain. तो मैंने कहा कि ठीक है, you give diclofenac, right? One diclofenac, कुछ खाया तो कहता नहीं. Now that gentleman wakes up at 10 o'clock, 11 o'clock, दोपहर को तो उठते हैं, right? And this pain developed. So I said, give diclofenac, he would be fine within 1 to 1.5 hours. If not, I'm sending you one more tablet. The message कर रहा हूँ. But don't tell him, because a very powerful painkiller is Robinexol. So I said, don't tell him, otherwise he'll say कि नहीं मुझे इससे फर्क नहीं पड़ने वाला, go for the higher one, because it is the psychology. So that's why never tell this कि दर्द हुआ. He will invariably say हाँ, right? The second, this is very common, muscle sprain. So even in general, the gym mein gaye, you went for the heavy lifting, right? Or you went for running. So after that, lactic acid accumulation is going to occur, and it is going to give pain, which will be relieved within 48 hours. Right? So that's why if this is the thing, just ask for recent physical activity, right? Powerful physical activity, and that thing would give you the solution. And again, this pain is generalized. And finally, what we talked about was psychogenic. In psychogenic, two major things. One, panic. This is the panic disorder. And second, anxiety. Panic is sudden, anxiety is gradual. You must have noticed that, and you will see many of the students अच्छी पढ़ाई कर रहे हैं, but then as the exam approaches, नहीं यार मैं पास नहीं हुआ. I always used to say, never say this, मैं पास नहीं हुआ. तो because एक बंदा बोल रहा है मैं पास नहीं हुआ, तो दूसरा बोल रहा है मैं पास हो जाऊंगा, right? एक बोल रहा है यार मैं फेल ना हो जाऊं, दूसरा बोल रहा है कि नहीं यार मैं पास हो जाऊं बस. Now, invariably, brain will register only those keywords. Brain will eliminate nahi. Right? Brain will remember fail, and brain will remember pass. So then the brain will work in such a way कि वो 100% fail. That's why कई बार नहीं बोलते. Many of your parents must be telling कि बेटा शुभ बोलो. What is that शुभ? मतलब sometimes I say कि यार अच्छा बोलना, भगवान ऊपर से जा रहे होंगे, बोल रहे हैं कि तथास्तु, जा हो जाए. But the reason behind it is that this is how the brain functions. So in case of panic, the pain, the onset would be sudden. And in anxiety, it would be gradual. That is when they are unable to take that pressure. As the market was falling, right? So it was falling gradually. So even the calls, right? Initially, साहब थोड़ा दर्द हो, अरे साहब मर गया मैं. Right? Now see that language itself, it keeps on changing. So, but this is the difference. Right? Panic, anger, anxiety. So diagnosis will be pretty easy. You know the person. But in such cases, you have to just ask the rest of the questions. It's not a problem. So now we go to this. So your foundation is now ready. Here comes your action. Right? This is what is called as the approach to DD, or the differential diagnosis. And our sir used to say, बेटा तू गोल्ड मेडल लाया ना, तो भी तेरा गोल्ड मेडल is useless if you can't differential diagnose, because no one is interested that किसी को सर दर्द हो रहा है, it's okay, I can tell you 25 good reasons of the headache. गाली बोलेगा, मुझे क्या हुआ है बताना. That's what everyone is interested in. So differential diagnosis is nothing but solution provider. If you are a solution provider, you are a winner in life, right? Irrespective of whether it is IT or medical or any other field. So here it is. First, patient has come up with pain. Remember, O, D, T. If we are studying medicine together, this thing you will hear from my mouth for more than 500 times. For every condition, I will say onset, duration, and progress. Now you know onset. शुरू कैसे हुआ? Sudden, gradual, right? And you know the sudden pain. Now it is like sudden pain. अचानक हुआ. Then which area? Where is it going? So, right, and it is since how many days? So that is duration. So onset, time, and is it radiating? Is going where? Right? Type of pain. So all the discussions what we did, right? This is, and plus you will watch for, is the patient sweating? Associations or the associated symptoms. Is the patient sweating? Is the patient breathless? Is the oxygen level falling? All those things will be helpful. So just in minutes or in seconds, you know. Second thing, baat karte karte, you just apply the blood pressure cuff, right? Because you need to take that. Two things would happen. When you are taking the BP, now the electronic instruments are there, right? So immediately they will start measuring it and they will give you the pulse also. Right? So over here, blood pressure, pulse. They will give you, correct? They will give you the important. On physical examination, inspection, what you will watch for, one, any injury, because if it is fracture, right? If it is fracture, it is injury, trauma, right? So just watch for any injury, trauma, deformity, that thing is apparently seen, right? Palpation, we talked about. In case of that osteochondritis, right? The patient, it would be reproducible. Right? In case of any of the musculoskeletal injuries, it would be reproducible. So is with the palpation, is the pain reproducible? When you press and patient jumps, right? So inspection, palpation. Percussion has little role, but still will just write for the sake of completeness of the topic in pneumothorax. But otherwise, so in pneumothorax, you just percuss and instantly you know, first thing which you'll be doing is go for X-ray chest, right? And the auscultation. So in auscultation, you need to listen for abnormal heart and abnormal respiratory system sounds. Right? Huge topic, right? All the rails, murmurs, all different types. But this is what really is to be done. Now, for the diagnostics, first ECG, because it won't take much time. And in that ECG, you will be watching for ST segment. Rest of the other things, they can be seen later, but watch for ST segment. It is elevated or it is depressed. Plus, what else you should really watch? Let's see. There is one more thing I would like to watch. ST segment is fine. What else I would like to see in ECG? Anyone? We talked about it. Shabash. T-wave. T-wave inverted. Correction. T-wave inverted. Right? That is what you would like, because it would be P-wave name. P-wave, so it is related to, right? This is the basic. Okay? So this is what we see. If it is chest X and second, you will go for chest X-ray. And chest X-ray will give you everything. So yeah, in this left axis deviation, right axis deviation, all those things, yes, you can. Right? It is part and parcel of it. But first striking thing, ST segment, if it is elevated, you know that you are talking about transmural. If it is depressed, ST segment, that means you are dealing with subendocardial. And if it is this T wave inverted, so this means it is acute. Right? So accordingly, you can take action. What is called as the MONA. Right? We'll come to that. So X-ray chest within seconds. Pneumothorax, right? Pneumothorax, you will know. So if it is pneumothorax, what will you see? Is there any mediastinal shift? So you will see that tracheal shadow, right? If the tracheal shadow is shifted, guaranteed, right? Mediastinum is shifted. So watch for mediastinal shift. Now you must have noticed, see, all these things, they are not rocket science, right? It is not that complicated. Medicine is as such, it is not complicated, but it is very systematic. You just see and you say, okay, yes, it is the middle lobe consolidation, and people will say, hey, it happens. But now you have seen so many X-rays that for the consolidation, whether it is upper lobe, whether it is middle lobe, or it is lower lobe consolidation, lower lobe consolidation, you can know, right? Lower, the dome, middle, heart, the border of the heart, and in the upper, that horizontal fissure that we see. When you are handling, first thing, immediately take the blood and send it to us. So that is what is called as the lab test. In lab test, all the tests are done, but we are interested in only two tests. One, troponin. And second, D-dimer. These are the two tests which are like gold standard. When you will be going for troponin test, right? We'll talk about troponin in slightly more detail. You took the ECG and it is showing ST elevation. First thing you will do is go for the troponin. Both, two types of troponin are there. Go for both of them. And 100% they will be elevated. You can even go for high sensitivity cardiac troponin. We'll just talk. And then the D-dimer. So what really happens is troponin, when you'll do ST elevation, go for troponin. Right? So if there is ST elevation, so that means it is confirmed that myocardial damage is there. Right? So you will also go for non-staining. ST segment elevation is not there. But if rest of the things are like the patient is having diaphoresis, abnormal sweating, patient is breathless, right? That ghabrahat, if that is there, then go for troponin. Because troponin is more sensitive, right? Before even ST elevation starts, troponin, it gets released into the blood with the myocardial injury. So it's if it is elevated, troponin level, that means the heart attack has started. The D dimer, this is, you can see it is like a screening tool for PE, pulmonary embolism. Pulmonary embolism, because pulmonary embolism is like a time bomb. And especially it develops when there is infection, right? In COVID, it was to that high level, like infection, and people were dying because of pulmonary embolism. So every treatment was given, but what is needed in this case is that blood should not clot. Right? So that's why anticoagulants of very high level they are needed. So in order to prevent this, so these were the lab tests, and then the advanced imaging test. And in advanced imaging, without worrying about the cost, if you are suspecting high D dimer, right? The high D dimer, and you are suspecting pulmonary embolism, don't worry much. Gold standard, again, this is called as the gold standard for two things. And this is CT angiography. So the dye is injected in the CT scan, and you just watch the presence of. Later on, I'll show you even these images. That same. We'll be keeping one session on CT scan. Yeah, but I'm waiting for let the GIT be over, so that one section all the way starting from neck level, because above the neck it is complicated. There are so many structures. So first, I should be thoroughly sure that your anatomy of the neck region is awesome. So then you will really enjoy the CT scan. Otherwise, you will feel like all those kilo makode ki tarah chote blood vessels. So important, but the size is very small. Neck in this much, right? There are so many structures which are not present in the entire body. In this much area, right? Inside. So there are so many structures. So that's why head and neck, starting from this point, all the way up to the pelvic level. Right? I'll show you. It is like a real person. Right? He was a prisoner and he donated his body, and then the sections were taken with a microtome, and then all those sections, real sections, right? Real sections. The total number of sections all the way from the neck to the pelvic level up to the thigh, right? Up to the thigh it was taken. 236 sections were taken, and then on one screen, on one side the real one, and second the CT. This would be the real one, this one would be the CT image, so that you can really feel, you can get the idea that how it really looks like. Right? So all those images, they are there, and when we'll study the CT, I'll show you these parts. So that CT angiography is crucial, because in that you'll be able to see this pulmonary embolism. Very well, right? It is like a clot. It is like a clot. So this is like a pulmonary artery and a clot which is over there. But this clot is just hanging over there. It is, if it is released, right? If it is released, so then that thing goes into the circulation and then God knows, right? That clot, it can lodge into brain. If it lodges into brain, so then that part of the brain is dead. right? Say when it happened to my auntie, right? The branch of middle meningeal artery, which was supplying to Broca's area, speech. Now today also her speech is improving, but it is affected. How dangerous! It could have been some other areas. If it goes into the coronary, so the game over, correct? So many. If it goes into the liver, so it can lead to liver infarction. If it goes into splenic artery, then it can lead to splenic infarction. If it goes into the intestines, then part of the intestine that gets infarcted, right? Mesenteric arteries, if it goes, so that is gone. So many complications. So in that, you can literally watch this thing. Right? So this is one. And second, very quick method. That is also very good. That is the echocardiogram. That is also very good. So in which you'll be able to see like say pericardium, tamponade, right heart failure, right enlargement, all those things they are seen. No doubt, XHS is always there, but this is much more powerful and much more effective. Right? Achha. Knowing this much, right? How will you manage the management? In management, chest pain management, two parts. All these things, they were like your thought processes into your brain you are thinking about. When you are managing it, one, is it life-threatening or it is not life-threatening? Now in India, what happens that when your internship starts, so it is divided into 4 quadrants. So 1, 2, 3, 4. One is where you did. So it is like your own Vishwa Medical College Civil Hospital. That is where you do the first quarter, right? It varies, but 3 months you do it over there. 3 months you have to go to some other college, other hospital of the same university. Third, you have to go to any of the hospital of the state. But this fourth one, this is where you have to go to any of the village. This is called as the primary PHC, primary health center. Now in this primary health center, जाने के लिए भी मतलब इधर यू आर गोइंग इन द ट्रैक्टर राइट, रेत का भरा हुआ ट्रैक्टर है, उसमें डॉक्टर साहब जा रहे हैं, ठकर ठकर पहुंचे तो मतलब भूत जैसे बन गए. You reach over there, right? But the respect and the love which they give you, amazing, right? रोज शाम हुआ, right? रोटी छाछ सब लेके आएंगे, सब खाओ. But it is at that point, if anything happens, then you are the only person, and you are the sole responsible person to handle any of the critical emergency, whether it is a snake bite or road pe accident hua, someone has come, and you are quite far from the hospital. This what the experience and the that gives, that is where you feel like कि जितनी पढ़ाई की थी सब was. So this is what you will do. Life-threatening or not life-threatening? If it is life-threatening, तो क्या? One, ACS, acute coronary syndrome. Right? You have no ECG वगैरह तो all those facilities are there. नहीं और कोई नहीं होता. There is like you are the doctor, you are the chief, you are the chief. There would be one compounder. Like our senior, no boss, you are the senior most. You are the senior most. You are the boss. Right? You are medical officer. So it is fully on you. Right? The rest are, there is a compounder and there is a pharmacist, there would be some 1 or 2 nurse, but you are the boss. Every decision will be, and that's why, right, in village, when you go, they feel like, oh, you are God. And if you have saved few people, to bas, rote hain. They used to cry, right? When you go back to then they will literally come up with, मतलब इतना बड़ा मटका भर के, sir, ACS is acute coronary syndrome. Acute coronary syndrome, right? Whether it is angina or it is or it is myocardial infarction. मतलब when I was leaving, that was the last day. मतलब वो मटका भर के इतना बड़ा, सर ये मेरी गैया का दूध से बना हुआ ये मक्खन है, then one was giving that ghee, all those things. अरे अभी आप इतने दूर जाओगे तो खाने के लिए, मैंने कहा मैं कौन से दूसरे देश जा रहा हूँ, right? It was a matter of 3 hours, but नहीं, पूरा खाना वाना बना के, इतना खाना कि it was sufficient for 10 people. But that's the love which you get. And it was that site where there was highway, and so accidents, they were so frequent. It was like a blind curve. It was like this. Our center was exactly over here. So we many times रात को बैठे तो we used to see a गाड़ी जा रही इतनी high speed पे, and यहाँ से truck bang on collision, and then you are running. So it used to, but this is that experience which gives you the confidence. It is necessary to study. So over here in ACS, remember Mona. This M stands for morphine. Morphine is normally you won't get it, right? Because it comes under narcotics. But yes, when the condition is like that, then it is. Then second is oxygen. O is oxygen. You have to give nitrates. You don't want the blood to clot. Aspirin. Aspirin, this is even one of the question of USMLE. First thing is give the aspirin and tell the patient to chew it. Right? Patient has to chew it. This is that crucial. And second is, and then you plan for revascularization. It's called as a revascularization. We'll discuss that. That is when you are going for, say, thrombolysis. This is especially when it is STEMI. I'm just writing the word thrombolysis, right? In case of STEMI. ST, elevated myocardial infarction, because we know that when the ST segment myocardial infarction is there, that means it is transmural. Transmural means it is full thickness. Which is pulmonary embolism. So now you should be able to diagnose, you should be in the situation to see that patient is having pulmonary embolism. How? Pleuritic pain, right? Pleuritic pain, we talked about it. Pleuritic pain is there, plus embolism, right? So see, how was the patient in case of pulmonary embolism? This is easy, right? That pulse oximeter you apply and you see less, right? And then the pulse oximeter itself will show you even the heart rate also, pulse also. It shows the pulse as well as oxygen. So you know that the rate is 110, 120, right? It is so high, but the oxygen level is dropped and patient is without speaking anything, right? He is bent, and you go for D-dimer. You find the D-dimer and D-dimer is high. When it is high, that means you are definitely going for the pulmonary embolism. Your patient is going for pulmonary embolism. So what you have to do? Gold standard is CT angio, right? But not everywhere it is available. So that's why you need to start anticoagulants. Like say heparin, all those things that we started. Then thrombolysis. Here also thrombolysis. That is needed. And if it is third, what we discussed was the aortic dissection. Aortic dissection is like an emergency, right? So what if you suspect that patient is having severe pain? Yes, you are giving morphine and everything, but blood pressure control, that becomes crucial, right? So blood pressure, the reduced. And for this, right, La Beta Law. Right. Remember this medicine, La Beta Law, right, beta blocker. So this is propranolol, esmolol, right, all those things. But this is the labetalol that is very powerful. And if it is type A dissection, then it has to be the surgical correction. That's what we'll see later. Okay, regarding the non-life threatening, so if it is pericarditis, you find that yes, it is, patient is having fever, and then yes, you give NSAID. NSAID is all your brufen and paracetamol and all they are collectively called as NSAID. NSAID stands for non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. Yes, if there is pericardial effusion, right? If there is a fluid collection, and in that, how the X-ray would look like, right? You remember we saw the case of pericardial effusion, and I told you that this is so important because as if this heart is sitting like a duck, as if duck ki tarah baitha, right? Because there is a fluid, here there is fluid. So this is remember, you can just have a look at that X-ray into our previous PDFs. Because if there is pericardial effusion on X-ray chest, don't give anticoagulants, right? You will worsen the situation. See over here, we are giving anticoagulants, aspirin, anticoagulant. But in this pericardial effusion, big and bold, no anticoagulants. That's why these X-ray chest, right? No anticoagulants. X-ray chest is so important. Simple सी चीज, but yes, it is so important. Rest of the condition, say if it is GERD, right? Gastroesophageal reflux disorder, process is very painful. So normal soda voda kuch nahi chalta, right? So for that, the best medicine, pantoprazole. Technically speaking, that how it works, it is what is called as the proton pump inhibitor. Now this is pure pharmacology. But not to worry. Itna yaad raha, bahut. Because when you will be learning it in more detail, automatically links will start getting established. And third, if it is muscular pain, chondrocorditis, costochondritis, just give analgesics. Analgesics are like Boveran, then diclofenac sodium, diclofenac potassium. If the pain is still more, then person can be given Robinaxol. All those are very high level of painkillers. But depending upon the pain and depending upon how the patient is responding, accordingly, you can take the call. Right? So I think we stop at this point. Tomorrow, we'll be discussing, it may happen that patient's life is gone during tests and tests. The doctor is only doing how situation. Yes, Kushi, it is like, that's why. Say, why the time is so critical. Your clinical judgment in those crucial stages. So when you see the patient, right, patient is having severe sweating, right? You know patient is difficult to breathe, immediately oxygen, morphine, all those things, so they should start immediately. So that you are just handling the patient in such a way that his life is saved. And how much time it takes for the ECG. Nowadays, so the patient is put immediately scissor, it is cut, right? And those electrodes within seconds, your monitoring starts. Right? The moment you see ST elevation, you know what to do. Right? So it won't take even 1 minute. It won't take even 1 minute. And meantime, oxygen and everything. Plus, you are examining that patient is having such pain, patient is sweating. So then we will not be thinking about other things. Right? So yes, but doctor is only blamed. Doctor is blamed. Say, being a medical, we should not blame the medical fraternity. But recently, I came across. Say, I'm not opposing Ayurvedic medicine, but I came across some of the Ayurvedic doctors, those who are doing allopathy practice, and with no concept, with literally no concept. मतलब patient, मतलब 8 patient admit करके रखे, and to everyone it is 0.9% and sodium chloride is going, normal saline. Everyone, I said कोई concept नहीं whether this patient का है. I said this is having, he is having edema, इतना बड़ा, मतलब there is swelling, मतलब he's, look at the foot. He said नहीं देना चाहिए. Then I realized कि no, this is, इसने डॉक्टर लिखा तो है. I said क्या सर आपकी डिग्री कौन सी है? तो क्या बस आप जो है ना MD लोग तो हमें इंसल्ट ही करते हो. हमारी आयुर्वेद इज दिस एंड दैट. I said forget about those things. इसको बंद करो and immediately start mannitol or Lasix. And we need to flush out the fluid, otherwise because of cardiac overload this patient would die. But no, they don't have that. So you are right, it happens, but sometimes these tests are important. Say for example, tomorrow we'll discuss it in more detail, because I feel that you guys, you are still, the strength is quite good. Okay. Tomorrow we'll discuss at length, right? Troponin and D-dimer. I'll show you the chart. I'll show you, or tomorrow I'll do one more thing. I'll also teach you the basic blood report, right? The basic blood report. How to look at the blood report. Normally कहते हैं ना CBC कराया, RFT, LFT blood report. We'll discuss that also. Yes. Sorry. We'll definitely discuss that. So, but yes, some let's say for example this troponin. So, troponin to immediate करवाना पड़ता है. Then after 3 hours, after 6 hours, after 12 hours, after 24 hours. So patient relatives they say कि अरे एक ही report 4 बार कराया, 5 बार, because it changes every hour, and it is the indication whether patient is improving or deteriorating. What are the chances of that he might be going into tachyarrhythmias, right? Ventricular arrhythmias. That's why it is needed. Troponin, both the types. Right? There are 2 types, troponin T and troponin I. And then there is on top of it, which is what is called as the high sensitivity cardiac troponin. It is HCCTN. That is something which is more specific. So tomorrow at length we'll be discussing. Plus we'll be discussing the routine blood report. Like what to see. What to see just from that report, whether the patient is having viral fever or he is having bacterial infection. Right? What can you really decipher from that basic report is what we'll discuss tomorrow. All right. And I think last time, I'm not sure if I have uploaded or not. By mistake, I have missed uploading that histology file. So I'll upload that and this file. Sure. All right. So thank you so much. And I really appreciate your patience. Thank you and take care. We meet tomorrow. You too have a very nice day.